Broadcasting from beautiful Sydney, the city of Opera House, Darling Harbour, Blue Mountains, and beautiful beaches. This is ICU Primary Prepcast, a monthly podcast about physiology and pharmacology in intensive care.
Hi, I'm Maddi.
Hi, I'm Swapnil. And today we are going to talk about another episode in physiology series, and that's about the obstetric physiology. Now, the obstetric physiology is really important and often asked in exam. And there are only few questions from this section. And if you know all these questions by heart, I think it's a very high-yield topic. Very commonly asked question, can you please outline the cardiovascular, respiratory, hematological, and genitourinary changes that occur during pregnancy?
So the cardiovascular changes, which we'll start talking about first, include effects on cardiac output and mechanical effects. In terms of cardiac output, the stroke volume increases by 20 to 30%. This mainly occurs within the first trimester. The heart rate also increases as early as 4 weeks after conception and increases by 17% by the end of first trimester and 25% by the middle of the third trimester, with no further subsequent increase. In terms of preload, there's an increase in plasma and blood volume, which mainly occurs during the first and second trimester. The ECF increases by 45% due to sodium and water retention as a result of increased estrogen and activation of the renin-angiotensin system. Blood volume also begins to increase in the first trimester and increases to about 35 to 40% by the end of pregnancy. In terms of afterload, total peripheral resistance decreases by 30% at the end of the first trimester and 35% by the 20th week, but then remains back at 30% below non-pregnant values due to the effect of increased progesterone and prostaglandins, causing vasodilatation and smooth muscle relaxation. This decrease in total peripheral resistance results in decreased blood pressure, with systolic and diastolic pressures decreased by about 10% and reaching their lowest values at about 20 weeks. The vascular system as a whole also becomes more refractory to the effect of vasoconstrictors. As a result of the above factors, cardiac output increases during pregnancy to 40 to 45% greater by 12 to 28 weeks and a peak of 50% during weeks 32 to 36, followed by a slight decrease to 47% greater than non-pregnant values at term. This is mainly due to that increased venous return secondary to venodilatation and increased vascular volume. A large proportion of this increased cardiac output is directed to the utero-placental circulation, which receives up to 10 times increased blood flow to about 750 mils per minute at term. In terms of the mechanical effects, the heart is more rotated to the left, which can result in Q waves and T wave inversion in the inferior leads on ECG. Edema occurs due to a 14% decrease in colloid oncotic pressure and the mechanical effects of the enlarging uterus compressing the lymphatic system. And the uterus can cause aortocable compression when the patient is lying on her back, resulting in hypotension and nausea. Coming to the respiratory changes, these include changes to the airways, changes to ventilation, changes to lung volumes, and changes in respiratory mechanics. In terms of the airway, hyperemia and edema of the mucosal surfaces of the airway results, which can result in difficult intubation. There is dilatation of the large airway, which decreases airway resistance by about 35%, and anatomical dead space increases by 45%. Coming to ventilation, minute ventilation increases by 20 to 50% due to an increase in respiratory rate and an increase in tidal volumes due to the effects of progesterone, which stimulates the respiratory centres. This results in a chronic respiratory alkalosis on ABG with a baseline pH of 7.47, a pCO2 of 30 to 32, and renal compensation with a baseline bicarb of 18 to 21. Oxygen consumption also increases by about 20%. In terms of lung volumes, tidal volume increases in the first trimester and rises to about 30% at term. functional residual capacity decreases by 20% due to the elevation of the diaphragm and an increase in pulmonary blood volume. In the supine position at term, the FRC decreases to 70% of the FRC in the sitting position. Inspiratory capacity increases by 10% at term, while the expiratory capacity decreases by 5%, and total lung capacity decreases by approximately 5%. And in terms of the respiratory mechanics, the diaphragm is pushed upwards by about 4% by end of term. Chest wall compliance decreases, while lung compliance does not change. The AP and transverse diameters of the thoracic cage increases 2 to 3%, the lower ribs flare out, and the subcostal angle increases. And the circumference of the thoracic cage increases by 5 to 7 centimetres due to the effects of relaxin produced by the corpus luteum. Coming to the hematological changes, these include changes to the coagulation and changes to a full blood count. In terms of the coagulation, there is a significant increase in factors 5, 7, 8, 9, 10, 12, von Willebrand factor, and fibrinogen, all of which can increase the risk of VTE. There's also a decrease in factor 11 to 70% of non-pregnant values. Protein S levels also decrease during pregnancy, and plasminogen is markedly raised, which is somewhat offset by plasminogen activator inhibitors, which are produced by the placenta. On a full blood count, you may see a physiological anemia of pregnancy due to dilutional decrease in hemoglobin and a relative leukocytosis. There is greater platelet production, but overall the platelet count is slightly reduced due to increased destruction in the uteroplacental circulation. And red blood cell volume increases by 20% due to increased erythropoietin. However, there is a slower rate of rise in red cell mass compared with plasma volume, resulting in a decreased hematocrit. And finally, in terms of genitourinary changes, these include mechanical changes and changes to blood flow. At 12 weeks, the bladder becomes an abdominal structure, and compression by the enlarging uterus can result in urinary frequency. There is also dilatation of the renal pelvis, calyces, and ureters, which begin within 2 to 3 months, resulting in physiological hydronephrosis. And in terms of blood flow, the GFR increases by up to 80%, resulting in a decreased urea and creatinine. Renal blood flow increases also by about 80% during the first trimester, and there is decreased tubular resorption of urate and glucose.
Thanks, Maddi. That's a very comprehensive answer. Now, another important part of the obstetric physiology is the placenta. Can you please list the functions of the placenta?
The placenta is a feto-maternal organ which consists of a fetal part that develops from the chorionic sac and a maternal part which develops from the decidua basalis of the endometrium. The placenta connects the developing fetus to the uterine wall. Development begins at 6 weeks and is completed by the 12th week. The placenta has 4 main functions: transport, immunological, metabolic, and endocrinological, or TIME as an acronym. In terms of transport, this is one of the main functions of the placenta. It transports the following substances: gases, especially delivering oxygen to the fetus and removing carbon dioxide from the fetal circulation; nutrition, such as water, and nutrients such as glucose, amino acids, fatty acids, calcium, iron, folate, and vitamins A and C. It also transports drugs, heat, and it removes waste and bilirubin. Coming to the immunological functions, the placenta provides passive immunity to the fetus, as it is selectively permeable to IgG, but not IgA or IgM. It provides a barrier between the fetal blood in the chorionic villi and the maternal blood in the intervillous spaces. There is little HLA and blood group antigens on the trophoblast surface of the placenta, so there is poor antigenic stimulus. The placenta also protects the fetus from some substance, especially those with large molecular weight or size, such as heparin, which aren't transferred. The metabolic functions of the placenta include the synthesis of glycogen from maternal glucose, which is then stored, the synthesis of cholesterol, which is a precursor to placental progesterone and estrogen, the synthesis of up to 7.5 grams of protein per day, and the synthesis of fatty acids. And finally, the placenta has many endocrine functions. It synthesizes multiple hormones, including beta-HCG, which is a glycoprotein that supports the corpus luteum in the first 10 weeks of pregnancy, and also has an effect of suppressing maternal immune function. It also synthesizes estrogen, which has multiple effects, including stimulation of growth of the myometrium and mammary gland development. It also suppresses gonadotropin secretion from the maternal pituitary gland. The placenta synthesizes progesterone, which helps to support the endometrium and suppresses uterine contractility. Both estrogen and progesterone are responsible for the majority of the maternal changes of pregnancy. It synthesizes human placental lactogen, which is involved in the regulation of nutrient supply to the fetus by inhibiting gluconeogenesis, is lipolytic, thus increasing free fatty acid. It promotes growth and has a lactogenic effect. Human placental lactogen is structurally similar to growth hormone. The placenta also synthesizes hypothalamic and pituitary-like hormones, including chorionic thyrotropin, chorionic adenocorticotropin, and gonadotropin-releasing hormones, as well as other hormones such as inhibin, relaxin, and beta-endorphins.
Great. Can you please outline the determinants of placental blood flow?
Placental blood flow consists of a maternal and a fetal part. Firstly, thinking about the maternal or the uteroplacental circulation, the maternal blood supply to the uterus is via the uterine and ovarian arteries, which then form the arcuate arteries from which radial arteries divide and penetrate the myometrium. The radial arteries then divide into spiral arteries, which supply the intervillous space. The fetal placental circulation has a basic structural unit of the placenta, which is the chorionic villus, which are vascular projections of fetal tissue surrounded by chorion. The chorion is composed of an outer syncytiotrophoblast, which is in direct contact with maternal blood within the intervillous space, and the inner cytotrophoblast. The villus capillaries are branches of the chorionic arteries, which are branches of the two umbilical arteries that bring blood from the fetus to the placenta. Oxygenated blood then leaves the placenta via the umbilical vein. In terms of the determinants of the uteroplacental circulation, one of the main determinants is blood pressure, as flow is passive and pressure dependent, not autoregulated. The pressure within the uterine arteries is about 80 to 100 millimeters of mercury, 70 millimeters of mercury in the spiral arteries, and just 10 millimeters of mercury within the intervillous space. This low resistant pressure gradient allows efficient maternal blood perfusion. Consequently, hypotension will decrease the uteroplacental circulation. Other determinants include vasoconstrictors, as the uteroplacental circulations exist in a state of vasodilatation, so vasodilator stimuli have minimal effects. However, vasoconstrictors such as alpha-adrenergic stimuli or sympathomimetic agents and severe hypoxemia can reduce placental blood flow. Finally, myometrial contraction can decrease placental blood flow as the intervillous space lies within the uterine cavity, and contraction will result in increased pressure within this space and therefore decreased perfusion pressure. Coming to the determinants of fetal placental circulation, this includes gestational age, as umbilical blood flow increases as the fetus grows, and also increases as the fetus moves. The other determinants are fetal cardiac output and placental vascular resistance, as increased vascular resistance decreases the blood flow. Therefore, vasoconstrictors can also decrease the placental blood flow on the fetal side.
Yeah, that's great. And in your one of the previous answers, you mentioned that the main function of placenta is transport. Now, can you please list the mechanisms of transport across the placenta?
The placenta has four main ways of transporting substances. These are diffusion, facilitated diffusion, active transport, and pineocytosis. Diffusion is governed by Fick's law of diffusion, where the rate of diffusion is proportional to the surface area, that is of the placenta, and the concentration gradient, and inversely proportional to membrane thickness. Examples of substances transported in this manner include water, electrolytes, and gases. Facilitated diffusion is transport by specific carriers down a concentration gradient, which does not require energy expenditure. Glucose is transported in this manner via hexose transporters. Active transport is mediated by specific protein carriers as well, but occurs against a concentration or electrochemical gradient and involves energy expenditure. Examples include amino acids, calcium, and iron. And finally, pineocytosis. This is the only way to transport molecules which are large, non-lipid soluble, and do not have a carrier. The substance becomes completely enveloped into invaginations of the membrane, and it is then released on the other side of the cell. Examples of substances transported in this manner include globulins, phospholipids, lipoproteins, and IgG antibodies.
Great. And placenta is unique in a way that you see double Bohr and double Haldane effect at the level of placenta. So what is double Bohr effect and what is double Haldane effect?
As we've mentioned earlier, oxygen transfer from the maternal to the fetal circulation is via simple diffusion down a partial pressure gradient of about 30 millimeters of mercury. This oxygen transfer is facilitated by fetal hemoglobin, which has a higher affinity for oxygen compared to adult hemoglobin and has a left-shifted oxygen-hemoglobin dissociation curve. Furthermore, the hemoglobin concentration of fetal blood is approximately 50% greater than that of maternal blood, thus also increasing the ability to carry oxygen. The Bohr effect states that increases in the partial pressure of carbon dioxide of blood or a decrease in pH will lead to a rightward shift of the oxygen hemoglobin dissociation curve, thus decreasing the affinity of hemoglobin for oxygen. The double Bohr effect describes this happening in opposite directions in the maternal and fetal circulations. Within the fetoplacental circulation, blood is releasing CO2 down its concentration gradient from fetal to maternal blood. The fetal blood is thus becoming more alkaline, leading to a leftward shift in the oxygen-hemoglobin dissociation curve, and thus increasing the fetal hemoglobin's affinity for oxygen. Conversely, within the uteroplacental circulation, the maternal blood is gaining CO2, leading to a rightward shift of this same oxygen-hemoglobin curve and encouraging oxygen release from the maternal hemoglobin. The Haldane effect describes the effect of oxygen on CO2 carriage, with deoxygenated hemoglobin having a greater affinity for carbon dioxide. The double Haldane effect refers to the fact this happens in opposite directions within the fetal and maternal interface. Within the uteroplacental circulation, oxygen is lost, thus increasing hemoglobin's affinity for carbon dioxide. Conversely, within the fetoplacental circulation, oxygen is gained, thus decreasing hemoglobin's affinity for carbon dioxide.
Thanks, Maddi. And another very commonly asked question in primary exam is about the differences in the respiratory system between newborn and adult. So can you please list those differences?
The differences between the respiratory system between newborns and adults can be divided into anatomical, lung mechanics, lung volumes, and respiratory control differences. The anatomical differences can be further subdivided into upper and lower airway differences. Coming first to the upper airway differences, newborns have a narrow nasal passage and a larger tongue and are obligate nasal breathers. Their epiglottis is stiff, relatively larger, and U-shaped, and at the level of C1, while in adults it's at the level of C3. Their glottis is also higher at the level of C3 to 4 with anterior angulation compared to C5 to 6 in adults. The cricoid is often the narrowest part in newborns, and this persists until the age of 8, which then it becomes the vocal cords, like in adults. Therefore, subglottic edema can cause severe respiratory distress in the newborns. The cricoid is opposite the level of C4, whereas it is C6 in adults. And the thyroid cartilage is flat and overlying the cricoid cartilage and the hyoid bone. Therefore, the space is difficult to discern. In terms of the lower airway, the trachea is short at 4 to 5 centimeters compared to 12 centimeters in adults, and has a diameter of 6 millimeters compared to 2 centimeters in adults. The right main bronchus is more directly in line with the trachea compared to the left side, and there's therefore an increased risk of right main intubation. The peripheral airways with a diameter of less than 2 millimeters contribute 50% of airway resistance, whereas they only contribute 20% in adults. They can therefore cause severe respiratory distress when diseased. And there is less bronchial muscle present in newborns, so bronchospasm is relatively less common. Coming to the lung mechanics, the chest wall of newborns is highly compliant, and the ribs and sternum are primarily cartilage, so there's poor chest wall stabilization. The ribs are horizontal, and there's no bucket handle pump movements like in adults during breathing, so there is minimal thoracic component to breathing. Instead, breathing is largely diaphragmatic, but the horizontal insertion of the diaphragm and low proportion of higher oxidative capacity fibers compared to adults mean it is susceptible to fatigue. Therefore, abdominal distension can cause severe respiratory distress. Alveolar ventilation is 120 to 140 mils per kilo per minute, which is twice that of adults, and newborns have short time constants. Therefore, their work of breathing is minimized at high respiratory rates rather than large tidal volumes. Finally, the ratio of inspiration to expiration in newborns is more like 1:1 compared to the adult ratio of 1:2. Coming to the lung volumes and gas exchange, the functional residual capacity of newborns is 30 mils per kilo, which is the same as adults, but it is less stable and more prone to atelectasis. The FRC is less than the closing capacity, so gas trapping due to the closure of small airways occurs during normal ventilation, and there is an increased alveolar to arterial PO2 gradient, which is usually about 30 millimeters of mercury compared to 5 millimeters of mercury in adults. Oxygen consumption is also higher on a weight basis, being 6 to 7 mils per kilo per minute compared to 3 to 3.5 mils per kilo per minute in adults. An increased metabolic rate and increased oxygen demand is aided by the high alveolar ventilation, high cardiac output, and distribution of high percentage of the cardiac output to metabolically active tissues. In terms of the respiratory control, this is less developed, especially in premature babies, and periodic respirations are common, with pauses between 5 to 10 seconds during sleep, occurring up to 6 times a night being normal.
Thanks, Maddi. So that's the end of our today's episode on obstetric physiology. Now, as per the tradition, there has to be a joke, which has become actually the trademark of this podcast. And I'm pretty sure this episode is not an exception for that.
No, it's not.
Okay. So yeah, please go ahead and ask me and humiliate me again.
Okay, why are pediatricians easily irritated?
Oh my goodness. I thought obstetricians are the one gets easily irritated. I was not sure about the pediatricians getting irritated. Geez, this is very difficult one. Sorry, buddy.
Because they have little patience.
Oh, buddy, your jokes are getting better and better. That's good. So, thanks, folks. So that's the end of our today's episode on obstetric physiology. So we'll be back in months' time with another episode in physiology series. Till then, goodbye and have a nice time.
Thanks for listening. See you next time.